6 o'clock now. Shall we get started? Hello, everyone. Welcome to the echo session for today, and welcome all our hub members as well as all the participants. We are very happy to have three speakers for today to share a case and also to go through some inspired talks with us on the management of pain. Today we will focus on the management of pain, which I'm sure is a very common problem we see in our clinics and with our clients, no matter where we practice. For today, we actually will have a different arrangement. We will first ask our presenter to present a case first, and this will be followed by two talks, and then we will go on to the case discussion. For participants, feel free to raise your questions either by raising your hand or putting your questions in the chat box. For those who have not for joining our echo session for the first time, please note that all the materials shared in these sessions, including the recording of the talks, all the slides, and also additional resources, all of these are available on the iEcho platform. And for now, may I hand over the session to Norman for some housekeeping and announcements before we start.
Thank you so much. For those of you who have been with us from the first session, this might sound like a broken record, but this housekeeping rules are mostly for folks who have just joined us today, and we welcome you. So if you haven't already, if you could change your Zoom ID, Zoom name to your name, your area of expertise and country, we would really encourage you to do that so that we know where you are, and we could direct some of our discussions based on the participants that we have today. As you've already heard, today's session is going to be a bit different as compared to our previous sessions. So it's going to be a bit informal, but we do welcome any questions, reflections, or thoughts, and feel free to drop them in the chat box. We encourage you also to turn on your video for us to see your beautiful faces, and also to encourage a more engaging learning environment. As mentioned, this session is recorded and will be uploaded on the iEcho platform. In recognition of the diversity of participants that we have, we recognize that not everybody's primary language is English. So if you'd like to have the content today being translated live, you could enable the translated captions function and choose the language of the captions that you'd like to be displayed on your end. In terms of CPD, Malaysian clinicians, we will submit your names to MMA to process your CPD points, but we would have to trouble you to complete a CPD form, Google form that we will drop in the chat box so that we know we have enough information to submit to MMA. Clinicians from Japan, you could submit your certificates of attendance at the end to JSAR to get your CPD points accordingly. And this certificate of attendance will only be issued once you've completed the feedback form. Clinicians from Australia, particularly S100 prescribers, we will submit your name to and the place of practice to ASHM for your CPD points to be awarded to you. That would be all for now. and I'll have more announcements towards the end.
Thank you, Norman. So may I now first introduce our first speaker for today. So we are very happy to have Mr. Yifan Feng with us today. So Mr. Feng is from Taiwan. He is an HIV advocate and currently serving as the Deputy Chief Executive of Harmony Home Taiwan and also the chairperson of Taiwan HIV Story. So Yifan has a strong political science and social services background, and he had been taking up leadership roles in the Harmony Home Foundation Taiwan for almost 10 years. And his current work focuses on strengthening Taiwan's HIV care infrastructure, promoting inclusive healthcare policies, and also fostering international partnerships to enhance HIV response. And recognized for his leadership and commitment, Yifan is also a Taiwanese Fulbright visiting scholar to the U.S. in 2024 academic year. His ongoing work continues to shape Taiwan's HIV response, bridging policy, community action, and healthcare innovation to create a more equitable and inclusive society for all. So today we are very honored to have Yifan to share a case with us, illustrating the importance of pain management in our everyday clinical practice. So thank you very much, Yifan.
Yifan, I think you're muted.
Yeah, Yifan, can you please unmute? Oh, yeah, okay.
Hi, thanks, Grace. Hi, friends here. Yifan again from Hong Kong, Taiwan. And today I will do the case presentation first. And, oops. Okay. Today we will have a case. Her name is Jen. She's 74 years old woman, and she identified herself as heterosexual. And she is also a former female sex worker. And now the current complaints she have is, the first one is she have severe knee degeneration and pain, especially during prolonged walking or standing. And she also have skin dryness or itchiness. She also fear of taking too many medications, and she have a little bit worried about that she cannot walk outside so frequently. So the first part is her mobility. As indoor mobility, Jane can walk independently to the restroom or up to the second floor without any issues. And we didn't find any balance problems or abnormal gaits observed, but she walked very slow. Her speed is approximately like 25 meters in 50 seconds. As outdoor activities, she walks very slow, and she is not able to stand or walk for a long time. And she usually uses wheelchairs for longer walk or longer activities outside. And as her limitations, we found that we cannot find any formal muscle strength test was done so far. And Jen reports that her legs have some soreness or weakness after walking short distance outdoors, even though it's to a nearby intersection. And she didn't have any knee surgery history. She has x-rays, and also recently she received a trigger point injection during the recent follow-up in March. And she was also most bedridden, even though she stayed in our shelter. And she occasionally go upstairs for food or snacks. And sometimes we will take her to the hospital for follow-up visits for checkups or OPDs. And about her health conditions, we found that her diet is normal and no swallow issues or difficulties. We didn't have any restrictions on her dietary. And her vision and hearing has both okay. So far, no problem. But she has sleeping issues. She cannot sleep very well. She has to take medicines. And she sometimes mutters at night. And we didn't find significant cognitive impairment, but she sometimes talks to herself, to the air, or to the walls frequently. So, well, we found that our observation. And we suspected that maybe she has schizophrenia, but she refused for further evaluations or treatments. But so far, we didn't observe any further aggressive behaviors. She was diagnosed hypertension in 2020, and so far she's in good condition, good control. About her daily functioning, she didn't have any disabilities. ADL score is 100 for independence. IADL, well, 0 points. And her physical activity is restricted by her knee condition, we have mentioned before. And her social interaction, well, very few interaction with other our clients or residents, but she communicates more with our staffs. About her social or life history, she's introverted and very passive in group activities. And she only responsive to food-related events. If we provide like pizza or fried chickens, she will come to join the events or companion. And about her family history, she's orphaned and adopted in a very young age. And she also experienced sexual abuse in her teenage. And then she left her adoptive family, and we found that she had been assaulted in very early age, and then she gave birth to two children. And then after she left her adoptive family, she began sex work at around 13 or 14 years old. And we didn't find any substance use history, only alcohol due to his previous sex works. Yeah. But so far, we didn't find she drinks in the shelter. And she's our client since March 2014 under Elder Protection Services. And we have mentioned that she was a former female sex worker, and she received money from the government, and also the welfare department will visit or do some resource referrals. And we didn't feel that she have significant habits or interest. She only wanted to visit the local hospital or shopping arenas for food or other essentials, daily necessaries. Okay, so here is her medical or OBD visiting histories. Majorly, it's ID OPDs from September in 2024, October, December. And recently, we have bring her to ID OPT in February and do the blood test. And in March, she have go back to the bone doctor for OPT and the trigger point injection. And about her vaccination, she has 3 doses of COVID vaccination, and she have flu vaccination last year in December. And so far, we didn't find hepatitis C infection so far. And about her CD4 and viral load, she has, well, relatively good CD4s, even though it's not very high. And she has been undetectable since 2020. And it is now her medication, majorly for like sleeping or hypertension. She has amlodipine for absorbital dinotrate, and she also have quetiapines. And for HIV treatment, she have Biktarvy, and occasionally she use some painkillers like cataflam or acetone. And also for the trigger point injection, here is the medication in the injection. And now she's used Biktarvy for HIV treatment, but previously she used Qibesa and Varamil. And here is the discussion for today's case presentation. The first point is about her knee joint pains and degenerations. And the second is about her mobilities, including her muscle strength or endurance. And then we would like to know more about how we can support her to do some more evaluation on the mental health or other health conditions, because she would like to deny for further engagement. Yeah, thank you.
Thanks very much, Yifan. So, as mentioned, we will go on with the two talks first, and then we will come back for the overall case discussion of the case and also other issues related to pain management. So, I'm very honored to introduce our second speaker for today, Professor Anwar Suhaimi. So, Professor Anwar is a associate professor in rehabilitation medicine at the University of Malaya. Professor Anwar is currently a consultant at University of Malaya Medical Center, and he has pioneered in musculoskeletal and pain rehabilitation in Malaysia. He has also expanded cardiac rehabilitation and also has led the COVID-19 recovery research. Professor Anwar is a certified interventional pain sonologist, and he has advanced digital health and regenerative therapies and actively contributing to national and international rehabilitation initiatives. So thanks very much, Professor Anwar.
Thank you so much, Grace, for the very kind introduction. And thank you again for the invitation. And thank you everyone for actually choosing to join us this evening. So for the betterment of our patients. So good evening from Kuala Lumpur, Malaysia. My name is Anwar Suhaimi, and I will use the case presentation that Yifan has shared earlier on, and I'll just summarize that for our discussion today. Okay, so as a stimulus, so we have a case of a 74 years old female by the name of Jane, who has complained of knee soreness that has affected her walking, her ability to stand for extended periods. And, you know, of all the things that she enjoys going out. You can hear that she loves food. You know, she's probably shying away from company, but she loves going out. And her current complaints are actually affecting how she access things that is joyful to her. So community access, and if she resorts to wheelchair, that's going to be another issue, right? Because not all places are accessible. So that is the complaint. But if you listen closely to Yifan's description, she is functionally independent. Within the setup that they have in Harmony Home, she is actually very independent in both personal and instrumental area, but she's affected by her soreness and the pain. So we are looking at pain, which I think is quite universal. I think all of us here also will have experience. If anyone here has not have pain, I would like to come and see you, interview you, and find out what you've been eating and what you've been doing, because pain has driven mankind. And I think that one of the biggest invention in the 19th century was morphine, and the only reason because it was pain. And that was probably the best thing they've invented since then until now, besides smartphones. Okay, so anyhow, moving on. So we are going to look at how we're going to address something that is quite common, but has been a big barrier, not just to participation, not just to daily living, but it affects quality of life significantly. And obviously, in my case, as a rehab physician, it affects function. Okay, so very quickly, most likely this lady is going to have, or probably has, osteoarthritis. It doesn't really take much for us to figure out. And as a matter of fact, over 60 years old, when you present with knee pain and you fulfill certain criteria from American College of Rheumatology, you don't really need expensive investigation to actually come up with knee osteoarthritis, which actually is almost a top 10 disease that affects globally in 2010. So it's about 10 years ago, but still, I think it's valid until today. It is a leading cause of middle-aged disability and gait abnormalities. Now, it doesn't just stop there. Gait abnormalities leads to high risk of falls and all the associated problems that you get from fragility fractures, from being bed-bound or chair-bound. And that is not just physical, it also affects psychological as well. And because of the increasing demand of surgical interventions to either address arthritis or the results of falls, there's actually a treatment gap between people who actually can get surgery immediately and those who actually have to wait. We're not talking about a fracture, that is urgent, but we're talking about knee replacement as the definitive treatment for knee osteoarthritis. At least in my center, is a few years wait for public side. So it gives us a big treatment gap that you and I as physicians or healthcare professionals who are interested in management of pain. Now, every time you see a QR code, I'm actually linking that to the reference or the literature that is relevant to that slide, okay? Just to save some space. Okay, I'm going to breeze through some slides. These are nothing new. So this is what we understand about pain. We're talking about acute pain that you feel, let's say if you touch a hot kettle or you touch something sharp, okay? So this is how our peripherals or our sensors at the end of the body talk to the brain. So as long as any of this system or any of this process is disrupted, you will not feel pain. So we give local anesthetic that sometimes blocks transmission. We can do other treatments to reduce the amount of information that goes to the brain and being perceived, or you can modulate that descending input. So this is nothing new. This is what we are currently understanding from science. But talking about chronic pain, this is when something that is sensory, something that you feel or perceive as pain, now becomes or has an emotion or an effect that is attached to it. So much so, when we are young, when we are naughty, what does our parent threaten to do? I'll bring you to the doctor. Why? What's wrong with us? What have we done to deserve that? It's because we are known for, poking and injecting and all other unpleasant things, right? So you have a emotion that is attached to this sensation. Now, give it time. As pain from acute becomes subacute, becomes a constant bombardment on a daily basis, you begin, or the person begins to then rationalize or begins to cognitate the pain. So you interpret the pain. So all of us can have similar diagnosis, similar pain, but your pain and my pain can be different because of the way of our experience in the past, of our emotions that's attached to a particular feeling, and how we brain the pain, how we interpret the pain. Next, this pain now can manifest itself in a behavior or physiological changes. What it means by this, you can have an adaptation, a behavioral adaptation to pain, or you can have a behavioral maladaptation to pain, which does not serve to improve the pain, but either propagates the feeling of the sensation of pain or propagates the affective or cognitive part of the pain. So you're stuck in a loop. Physiological manifestation, you can have things like resting tachycardia. You can have a stress response. You can just be very sympathetic just because of prolongation of the pain sensation. Now, down the line is when we get to chronic pain. So you can see right now, we're not talking about pain as the feeling, but look at that. We're talking about pain as a behavior. Don't you have patients coming to you say, doctor, I feel pain. And another patient say, doctor, I'm suffering from pain. Why the different words? Because remember the previous slide I was talking to you about how feelings, how cognition is attached to the sensation of pain. So now patient not just experiences pain, which is the blue circle, they've moved on to the cognitive and the behavioral domain of pain. And this model of pain explains how or why we see some patients with chronic pain, the initial acute injury is gone, but the patient still sustains to have complaints of pain. Okay, so very quickly, what is rehabilitation? A lot of times people confuse this with drug anonymous, alcoholic anonymous, but it's actually a medical process of helping an individual to achieve the highest level of functional independence and quality of life. Okay, so we work in a team, and you will meet the rest of the team later with the next speaker. Now, to understand how we see a disease, we as in people from rehab medicine. As a matter of fact, I don't think this is an exclusive concept to rehab. I'm looking at the ICF, International Classification of Functional Disease and Disability, basically using the knee osteoarthritis as a model or as a concept to understand how this ICF concept goes around. Let me bring my pointer up. Okay, so we have any disease up here. So we use knee osteoarthritis. Can affect a patient or an individual either through the body function or structures, or changes in activity, ability to do activity, or changes in participation levels. So body function or structures, or known as impairments, are basically any condition that can affect how we function or affect directly the structure. So in osteoarthritis or any musculoskeletal complaint, the top 4 impairments or effect of body function structures will be pain, reduction in range of motion, some degree of joint deformity, either in terms of bone enlargement or deformity, and also weakness. So these are the 4 commonest in any sort of musculoskeletal problems. Then you can have issues because of pain, you can have sleep disturbances, because of poor movement patterns, you can have fatigue, and so on and so forth. Notice that the arrows goes both ways. So meaning that anything that affects impairment can lead to problems performing activities. And we have categorized activities into personal activities of daily living, things that you and I need to do for us to be able to come to this Zoom meeting, get dressed, feed ourselves, go to the toilet, and wash up after ourselves. So all of this can be affected by a disease differently. So you and I may have osteoarthritis, but your osteoarthritis is not the same as my osteoarthritis because our impairments might be different. The way the impairments affects our ability to do activities might be different. And as a result, our participation levels can be different. Now, all of us, participation refers to our role. So all of us at least has 3 or 4 roles. I'm a student and I'm a teacher, I'm someone significant, others, and so on and so forth. So the same thing goes for our patients, same thing goes for you. So participation here can be at family, at community levels, and to a certain extent, it will be definitely be affected by the ability of an individual to do daily living activities independently, and of course by the actual reason why they can or can't, because of things like pain, reduction in range of motion, etc. Now, here's the game breaker for me sometimes. You can be disabled or unable just because the environment supports you. So in a place, for example, at the hospital where, it's wheelchair accessible, you've got ramps, you've got handrails, somebody who's like Jane may not be disabled after all. They have plenty of chairs, good lighting, but turn that scenario around, put her in a dark alley, no lighting, very irregular surfaces, she will be automatically disabled. And the thing is, the same thing goes for us as well. Like say, I'm short-sighted. So if you put me in a place, take off my glasses, turn the light off, I'll be disabled to a certain extent. So these environmental factors really is something that we should look into and try to adapt or fix it for our patients. Now, not forgetting, if you remember from Yifan's presentation, the patient is now presenting either with symptoms from either psychology, geriatric depression, or or other causes. It could be, so we'll talk about that in later. So all of these personal factors, obviously, and remember, the arrow goes both ways. So your disease might not be the same as my disease, although the diagnosis is similar, just because we have got different factors that is going for us or against us in different ways. So I hope we understand this, because from now on, understanding how rehab process works and how we intervene really depends on our understanding of ICF. Okay, So at this point, I'll just want to quickly show you that ICF is used not just to understand how the disease interacts with a person, but also in the whole rehab process. So if I can break down the rehab process, make it easy for you, it's EIO, evaluation, intervention, and outcome. So the picture here, or the image here, is just to simplify the fact that we use ICF as a concept, both during assessment and during intervention and during the outcome evaluation of whether our intervention actually is bearing fruits. Of attaining functional goals. So you can see that ICF comes in at every corner because it's a way for you to understand how this disease affecting Jane, or this disease affecting Jane's housemate. They might be similar diagnosis, but it can affect you differently, and therefore your intervention and outcome cannot be the same for all because they have got different factors that's assisting them and affecting them. So essentially the rehab processes can be broken down to this three activities that is done in a cycle to achieve a particular functional goal. If the goal is achieved, well and good, we move on to the next goal. If it's not achieved, then we will reassess again, find out what went wrong, how we can improve that, and then proceed with this rehab cycle. Okay, so I'm putting Jane back into this picture. So we have knee osteoarthritis, most likely in her case, because that's a complaint. So she complains of knee pain, and that's affecting her walking speed and how long she can stand and walk without aids. That's affecting her community access, and also if she's going to be wheelchair dependent, then it will depend on whether the area is wheelchair accessible or not, and that can be an environmental issue or environmental barrier. Now, remember, Jane is very independent in her living area because of her small room, small living space, so she can skirt around. She knows the corners very well, where to avoid, where the steps, etc., etc. And she also has got other personal factors, which can be, in her case, not just the age, but also the psychological state that she may, because the word may is because we haven't really assessed, but there's a few guesses that we can do. Now, just to show an example, so using again arthritis, I'm sure some of these measures are very familiar to you. For example, like WOMAC score, which is often used to assess how bad the arthritis is. Because if you were to just use Kerguelen-Lawrence scale, Kerguelen-Lawrence is just to stage an X-ray, and really for us physicians, it's only useful for the surgeons because the surgeon needs to decide what kind of hardware will go into a patient with this stage of a disease, rather than stage 4 Kerguelen-Lawrence, disabled. Because I find a lot of patients who are in advanced stage of arthritis, but very and fiercely independent. So WOMAC Kerguelen-Lawrence doesn't really tell you much. But scales like WOMAC and KOOS, knee osteoarthritis outcome scale, are very useful because they cover a few domains: pain, symptom, activities of daily living, even up to sports for KOOS. So we can establish outcome measures, but apply them in the ICF concept. So now we can just take the KOOS subset for pain to understand how the knee pain is affecting the body function or the impairment. And we can use, again, standardized measures that I think the next speaker will probably spend some time talking about, like to assess mobility objectively. So it's not about what the patient feels, it's how they perform. And that's very important because we need to be objective in our intervention, in our outcomes. And again, using KOOS to assess more softer, more intangible domains like function. How do you know how functional you are? So you can look at the way whether they are able to participate in sports, or they can go out to work, or what's their quality of life. Okay, so again, that's an example of using ICF for the purpose of intervention. Now, coming back to what I do as a rehab physician for knee arthritis, I don't think, again, it's exclusive, but just to understand how rehab team works. So mainly my intervention or my rehab intervention in terms of evaluation, intervention, or outcome, EIO, is targeted towards the main impairments of musculoskeletal problems, which are pain, loss of range of motion, weakness, and joint deformity. I put in my process into 3 R's. So whatever I do, I try to relieve pain. And nowadays, with the advancement of regenerative medicine, which I will touch very briefly for the sake of time, and probably talk more of it during the Q&A, we are now able to regenerate to a certain extent. And then when we talk about regeneration, there are many structures in the knee. So we can say that the patient has got knee pain, but the pain may not entirely come from intra-articular. It can be peri-articular or referred to the knee rather than actually originating from the knee. So the ability to actually find out where it is and have a targeted intervention will bring much better outcome rather than having it diagnosed in a much expensive way. AKA, patient goes for knee replacement and comes back with similar pain. Then you'll be like, ooh, it was not from the knee after all. So nowadays, with the advancements of technology and also advancements in therapeutics, we're able to regenerate, and then I'll proceed to rehabilitate. So this is the general form of how we proceed with treatment in rehab medicine. Okay. So again, the two most commonest things you will hear when we talk about regenerative therapy is prolotherapy, orthobiologics. What's the main difference between the two? Orthobiologics use cells, real cells, patient's cells. And prolotherapy uses, well, by virtue, prolotherapy induces inflammation, and the end result of inflammation is scar formation, fibrosis, that strengthens the tissue. So again, there's nothing good or bad about this. There's two options. It's just applying the right treatment to the right targets. And that's what we are getting more and more knowledge right now. So if you were to look into PubMed or any medical literature over the last 10, 20 years, you're unable to find much concrete evidence to support this, because we were just putting it in there and expecting miracles to work. But now we understand that in order for therapeutics to work, you need to put the right drugs to the right place. So again, I won't go into much. Maybe during the Q&A, we can talk a bit about this. The pain community is now beginning to look towards regenerative medicine to answer pain, and not just steroids, lidocaine, as the good old school of thought. Okay, so we are moving towards that. Okay, so very quickly, if we were to look into management of osteoarthritis, the non-surgical, non-arthroplasty, non-surgical part of management, the main goals is, again, I think it's quite aligned to what I said earlier on about my 3R: reduce pain, to improve function with whatever that's have, and essentially prolong the natural history of getting into a surgery, a replacement. Because although we think that surgery is the gold standard for osteoarthritis, all hardware has got a lifespan. There is an expiry date. So if you get a knee replacement at 60, your next knee replacement might be scheduled at 75. So is it a good idea to go in under the knife at 75 plus? Again, if you get it at 70, if you're going to get in at 85. So that's the question. So we try to delay surgical intervention as much as possible. And thankfully, there are ways of doing it. So in the past, this is the standard. We've learned this in medical school. This is the standard treatment progression. So we have got conservative management. You have some over-the-counter drugs. We tell the patient to lose weight, which I think is some of it chicken and egg. Patients got knee pain. How do you tell them to exercise? Well, I'm pretty sure my next speaker has got a few ideas which we can try in our patients. The use of orthotics, walking aids. Okay, and the asterisk here is because exercise, despite whatever they say, has always shown benefits to our patient, regardless of age, regardless of their physical status, and regardless of how advanced the knee osteoarthritis is. Exercise has always been quite standard and has got good support in terms of evidence. So a formal physiotherapy referral to have not just any random exercise, but a proper therapeutic exercise prescription. So like how we prescribe drugs, exercise should be prescribed as well. Corticosteroid injections, the use of orthotics or a brace. And again, if this fails, we're going to go over to the higher end stuff, the use of things like hyaluronic acid, PRP, which is an orthobiologic, or denervation, which I'll quickly talk in a while. And boom, the last bit is surgical consult for possible hip joint replacement. But we can change this by a couple of things. So I think what I'm going to do here is basically show you how we use the ICF model, which is again through evaluation, intervention, and outcome, taking you through the same pathway that we've seen earlier on. And I'm just showing you here how assessments can be done using function as an outcome rather than pain. I'll repeat that again. We use function as an outcome in comparison to pain. So although we are treating chronic pain, but you must understand, when the pain has already become a behavior, has become an identity of the patient, it's very difficult to get an identity out of a person, right? So we then shift our focus towards function. So this is then where this focus of treatment has changed and is going more towards restoring function. So this is a typical, and this is a very quick picture of showing you how we can block nerves around the knee. Now, usually we do this in outpatient setting, and it's always been described in terms of reducing pain. But now the shift is again towards reducing or improving function. Maybe by the virtue of reducing pain, but this pain reduction will then be followed by exercise, will be followed by lifestyle changes, will be followed by environmental modifications. And that is where the difference between just stopping at pain or going towards functional improvements. Again, a paper that we published in Korean Journal of Pain, and this one, in this study, if you were to look at it, we took in patients who failed conservative management, and we give them a single injection just underneath sartorius muscle under ultrasound guidance, which looks like that. Mid-thigh, just a single injection up to 3 months. Pain improvement, improved participation in physiotherapy, and better functional outcomes in KUS assessment. So you might want to consider that there is an option that is not surgery, and since the patient is very concerned about the amount of drugs that she is taking, this definitely can reduce the amount of analgesics and the side effects that the patient may have to endure. So in conclusion, we need to consider a disease not just as a diagnosis, but how it affects function, either in the forms of body function and structure, activity limitation, limitation in participation, and also consider specific environmental and personal factors that can influence the impact of a disease. Rehab process is not a mystery. It's done in a cycle that involves evaluation, intervention, and outcome assessment that is directed towards specific goals. And what I do mainly as rehab physician is to address the pain, range of motion issues, weakness, and also the joint deformity. And with the team, we look into rehabilitating the patient in terms of attaining functional independence specific for the patient. With that, thank you so much, and back to you, Grace.
Thank you very much, Professor Anwar. So we will now introduce our third speaker for today, Mr. Kenneth Chung. So Kenneth is a registered physiotherapist in Hong Kong and is currently an assistant professor of practice at the Hong Kong Polytechnic University in Hong Kong. And before joining the university, Kenneth actually has been working for a long time, providing physiotherapy service at the Society for AIDS Care in Hong Kong, which is a community-based organization providing care mainly for people aging with HIV. So having said that, I'm sure you would agree with me that Kenneth is probably one of the most experienced physiotherapists in the region, working with people aging with HIV. So thank you very much, Kenneth, for sharing your experience with us today.
All right, can you see my slide here?
Yeah.
So thank you, Grace, and thank you, Professor Anwar, and thank you, Yifan, for the presentations. So I think Professor Anwar already introduced a very good example of the ICF models. So today I will also incorporate the ICF model into the case study, and also I will briefly introduce what are the physiotherapy management for the osteoarthritis, and also how we will manage the pain based on the case presentations. All right, so without further delay, so let's talk about, I think the Professor Anwar already introduced what is ICF here. So in ICF, we have the health condition here, and the health condition will affect the body functions, the impairment, and body functions will also affect the activity and eventually affect the participations. At the same time, the environmental factor and also the personal factors will affect the whole, all the aspect here. And take the case say examples. Today we have Jane, and she got the major problem of the knee osteoarthritis, knee degenerations. Then the knee degenerations will cause the basic problem about knee pain, inflammations, reduced joints of range of motions, stiffnesses, muscle weaknesses, and reduce the muscle tolerance. And these basic impairment or sign and symptom will further affect the functions. For example, she has difficulty in walking outdoor, slow walking speed, poor endurance in outdoor walking, and she required a wheelchair to ambulate in outdoor. And further, it will affect the social participation, such as she cannot have limited outdoor activities. She has difficulty to do the shopping or go to the restaurant to eat the good food, and eventually she has a social isolation. So these framework help us to understand comprehensively. So it's important for us to make a further judgment on what kind of services we should introduce to her. And because in Hong Kong we usually adapt into a multidisciplinary approach, or what we call interdisciplinary approach, and these guidelines or this framework can help us to think what kind of service should be provided to the patients. At the same time, the environmental factors such as how the family support and trust me, with a good family support makes a huge difference to no support. And then what is the living place, small or big, and also what are the surrounding supporting facility available, and also will affect the outcome of the patients. At the same time, the personal factors, old age, suspected mental health problems, and also the lack of the awareness to the self-help problem will also affect the overall the outcome. So if we have a clear ICF model, so we can incorporate the multidisciplinary or interprofessional rehabilitation better, because every healthcare professional here are all aim to help the patients to provide the holistic health. And this is a very common practice in Hong Kong, no matter in hospital or in the community setting. So as a physiotherapist, as a part of the healthcare team, we usually will focus on the impairment, the basic signs and symptoms, and also the functional activity that related to the client. For example, the environmental factors can be important factors for social workers, or maybe for the occupational therapists, because they are doing some home modifications. For the personal factors, that may be more important to psychologists, or can be more important to the mental health practitioner. So come back to the client's problems. So today we have a client with the knee problems. So obviously she got a knee degenerations. So she has the knee pain, soreness in the knee and calf, knee stiffness, reduced range of motions, and muscle weaknesses. So as a basic problems, as a impairment level. So in the functional levels, she cannot walk too long. So but the point is here, the special things for Jane is she can actually walk indoor very well, but she cannot manage the outdoor walking. So you can think more why she is independent in indoor, but is very disabled in outdoor. So what is the differences between indoor and outdoor walking? First thing, indoor walking usually will be a flat surfaces, okay, easy to walk, so do not have a very high and lower slopes, or stairs, maybe not too many. But in outdoor walkings, we have uneven surfaces, we have up and down stairs, we have upslope and downslopes. That makes the problems. If the patients do not have a very good endurance, or the balance is also impaired, so that may make some difficulty in the outdoor walking. So the Jane also rely on the wheelchair in outdoor. This is also a kind of problem. And in terms of the social participations, so she has limited walking outdoor activity, and also may have the social isolations. So now we are going to talk some guidelines, or clinical practice guidelines that has been reviewed in Hong Kong physiotherapists. So we did a review. We collect most of the available clinical guidelines for the hip and knee osteoarthritis, and then this article actually makes some good recommendations on what kind of therapy should be introduced and what kind of therapy should not be introduced. So make a brief summary here. So first thing we are usually doing is a kind of a massage therapy. I think everyone likes massage, right? Because someone do something to you and you are very comfortable, and then you can just lay down and then enjoy the massage, right? Massage therapy is only conditionally recommended only. Okay, so you can interpret it conditionally recommended. That means not always, right? So just in some conditions, in selected group of patients, you can do massage therapy. So the massage therapy in osteoarthritis is not talking about massaging your joints. Okay, usually we're massaging the soft tissue, because usually knee osteoarthritis is not only the problem of the joints. Okay, usually it's also affecting the surrounding soft tissue. So we know in our knee joints we got a lot of the muscles attached next to the joints, and we have usually for the chronic pain patients usually we incorporate with the muscle tightness, tendonitis, tendinosis, or tendon adhesions. So those soft tissues surrounding the knee joints will also affect the knee pain, right? And some of the patients, actually, the pain sources is not about the knee joints. Okay, some of the patients also the main problem is the soft tissue pain, and the massage therapy can help him or her to loosen those ice tissues. We can use the massage therapy to improve the circulations by some maneuver, and if the problem is surrounding soft tissue, usually the massage therapy can reduce the pain. Okay, so that's why massage therapy is just conditionally recommended. So we need to assess whether the pain sources is at knee joint or is actually come from the surrounding soft tissues. And apart from the massage therapy, we got a lot of the electrophysical modalities. So in short term, we call it EPT, right? So in physiotherapists has a lot of machines, a lot of things to help the patients to make the feelings better. We can have we can just do a hot pack, okay, heat therapy, infrared therapy to warm up the joint or the soft tissues. And by increasing the temperature of the soft tissues, that we improve the circulations and the pain may reduce. We also got TENS, okay, it's a kind of the lower current electricity to stimulate the fibers inside the nerve, and using the gaze blocking mechanism to cover the pain sensations. So TENS is also another types of the pain therapy. We have a pulse electromagnetic therapies using the magnetic energy to stimulate the soft tissue growth and repair. We have a lower energy laser here. Laser is also a kind of the regional soft tissue stimulating therapy to promote the soft tissue healing, reduce the inflammation, something like that. And nowadays, a very commonly shockwave therapy is a kind of a very commonly and favorable therapy for the physiotherapists and also for the patients, because shockwave therapies is a kind of therapy that will produce a micro damage, okay, a kind of micro damage to your soft tissues, and then we initiate the healing process. Okay, so it is particularly suitable for chronic pain, because for the chronic pain patients, usually they have a lot of the adhesions, scarring around the knees, and also a lot of the tightness of the muscles. So the shockwave can actually produce a micro breakdown and micro damage to the tight tissues and allow the tissues to regenerate at the same time. So this is a very popular therapy nowadays. And also the last type of the modality is acupuncture. So in acupuncture is a kind of Chinese terms. In Western term, it's called dry needling. Okay, they are not exactly the same, but they are also using a needle to create some therapeutic effects to the soft tissues. And yeah, so because the time limitations, I cannot explain each therapy one by one, but overall, these therapies are conditionally recommended to some selected cases. But I would like to highlight that even though these therapies looks good, but I would say we will avoid overuse these kind of passive therapy. So what are the similarity of these kind of therapy? They are all passive, right? So what is the meaning of passive? Patients just lay down, sit down, and do nothing. And we do everything to the patients. So this is passive, a kind of passive therapy. But the problem of the passive therapy is usually this kind of therapy is addictive, right? The patients will addict to this kind of therapy, always asking for massage, always asking for acupuncture and something like that. And we know that this therapy can only provide short-term relief. Okay, if we just do this kind of therapy without doing anything, usually the pain relief will be very short-term. Okay, last for 1 day or 2 days, and the roots of the problem will not be solved. All right, so if we just do this kind of the passive therapy, I would say that in the long run, it's not going to help. So, so how we use this kind of therapy? Usually, we use this kind of therapy as a open a kind of therapeutic window for the main course. All right. So I will say this is a kind of appetizer in the course. All right. We use that only to create a therapeutic windows for the later therapy. So what should be the next? It's about exercise. Okay. So this is definitely echo to the presentation by Professor Anwar. Exercise is strongly recommended. Okay, for every patient, for every age, in every conditions. So we know that exercise therapy is a kind of big word here, okay? So according to the ACSM and American College of Sport Medicines, we can divide the exercise therapy into 4 types. First type is aerobics. Second type is a strengthening exercise. Third type is the endurance exercise. And the final type will be the flexibility. So aerobic exercise is good to improve the cardiovascular health. Strengthening exercise is good to improve the force generation by the muscles. Endurance exercise is particularly important for the muscles to work longer, okay? Work longer time. And the flexibility exercise help us to improve the range of the motions and also the how easy we move our body. So go back to the case here. So what do you think about which type of exercise is top priority for Jane? So everyone may have different choices, but for me, I will definitely say that endurance exercise should be the key, because the main problem of Jane is she cannot walk too long, so that she cannot walk outdoor, right? So she is actually okay to walk indoor. She got the reasonable strength, she got a reasonable flexibility so that she can manage indoor. But why not outdoor? Because she got no endurance. So to me, the top priority for Jane should be endurance the exercise. And the key to deliver endurance exercise in general, we need to introduce a kind of low loading but high repetition exercise. So I will talk more in the later slide. So second kind of therapy that is strongly recommended is a water therapy. Okay, to be precise, this is actually a kind of aquatic exercise. So aquatic exercise is not talking about swimming. Okay, don't mix up these two. We are not swimming. We are doing some exercise in a water. So you will see the picture over here. So the picture here is demonstrating a group of the patients. I think it's children. They are doing some exercise inside a kind of swimming pool, right? So the reason of having the exercise in the water, firstly, usually in the aquatic therapy pool, the water is a kind of warm water, okay? Not hot, not cold. It's a kind of warm water. Warm water will facilitate the circulations, okay? The patients will feel comfortable if he or she is working in a water and warm water. At the same time, the buoyancy of the water can reduce the body weight in the water. You will see from this diagram, if the water level is at the pelvic level, your body weight is already reduced for half already. So you'll find that a lot of the osteoarthritis of the hip or knee has the problem of the weight bearing, okay, because of the weights, right? Because the gravity, because of the damaged joints, they will be difficult in doing some kind of activity on land. But in the water, okay, if you're doing the same action in water, okay, for example, the water level is about pelvic level, she can actually do jumping, okay, or squatting. Okay, a lot of the actions that cannot be done in land, they can be done in water. Okay, so this is another advantage for water aquatic exercise. And then also the vigorosity can provide the variable resistance. So for strengthening purposes. So let's say try to walk in the swimming pool only. Okay, compare walking on land. The energy expenditure compared to walking on the water is huge differences. Okay, the energy expenditure in water is much higher because the water provide the resistance to you. So these features of the waters provide a very good kind of training, especially for the lower limb weight-bearing joints. Okay, so that's why this kind of exercise is strongly recommended for osteoarthritis of knee and hip. But the only limitation is that the facility limitations, because we need to have a swimming pool, we need to have a hydro pool, so that you can do this kind of therapy. So that is a limited by the facility itself. If the patients cannot go out, usually that will not be very feasible. And one more thing is about the manual therapy. So manual therapy is a very good strategy to improve the range. So for example, the patients got limitation on range. So we can do a lot of kind of the manual therapy to help the patients to improve the joint range. If the range of motion is limited by the tightness of the muscles, we also got a bunch of the techniques to improve the flexibility. So sometimes the patients need our help manually to improve the joint range and also the tightness of the soft tissues. So we have a lot of the approach. We have mainland, we have vacancy, we have mulligan, we have lots of techniques to help the patients to regain the range. But this is conditionally recommended only because we usually will not do manual therapy alone. Okay, this is just help us to improve the range. But later, after the manual therapy, it should be incorporated with the exercise. Okay, usually we will do the manual therapy and then facilitate the patients to do the exercise, or patients doing the exercise and we apply the manual therapy at the same time. Okay, so we seldom just do the manual therapy and done. Okay, usually this is not our practice.
And if you
And
have 1 more minute.
oh, sorry. Okay, so quickly. So also use of the walking aids is very important because some patients really got pain and in walking. So we might introduce the knee brace or some appropriate the walking aids. And finally, the patient education is the key because we need to educate the patients to do the long-term care by himself or herself. And one very important thing is we need to motivate the client because we are not assigning the assignment to the client. We are discussing with the client what kind of therapy she's needs to have. For example, I know the clients like do shopping, so I will ask, so I know you like go out and do the shopping, but this is limited by your fitness. So now I'm here to help you to be stronger and help you to go back to shopping again. Do you agree? So we try to align the goals with the patients, and we are not assigning the job to the patients. For example, I know that the patients want to get rid of the wheelchair, so I'm here to help you. Do you agree? So we're aligning the goals and expectations. This is very important to motivate the clients. So shortly, so what I would recommend to James, firstly, I would do massage therapy and EPT to reduce the pain, make her more comfortable to start with, and then we use the manual therapy and stretching exercise to improve the range. Right? Because she needs to have the range before she can do the exercise. After all these preparations, we introduce a endurance exercise training. We can do a non-weight bearing exercise, progress to weight bearing exercise. If the patient has difficulty in weight bearing, we can introduce the body weight support walking like this. The machines will take up parts of the body weight, for example, from 10 to 40% to allow the patients to have a more easy walking on the ground. We can also introduce the aquatic exercise to the patients if the facility is allowed. Also, I will try to improve the up and downstairs ability to prepare the patients to go outdoor. And finally, I would like to make the therapy go back to the functional level, so that he or she can use the training effect back to the outdoor environment. For example, I will ask him or her to go to the nice sea view with the nice flat surfaces here. Start with a flat surfaces and walk with her, and try to give her some rest if she is practice. And progressively we move to the walking in uneven surfaces, up and down slope, and up and down stair. And eventually, finally, I will go shopping with the client. And finally, more importantly, client education. Make sure that she know how to do the exercise, she know how to manage the symptoms, and that should be the goal to the long run. More options. Nowadays, the community want to make the exercise or training more funny. So we will introduce the VR training game, AR training game. That is a very common trend in nowadays. To summarize, the physiotherapy should match the client problem, concern, and also the expectations. And also, we are doing a patient-centered care. We allow the clients to participate in the planning. So what he is concerning, what is her expectation is always important. Try to find a way to motivate the client, not assigning the job to her. Always go back to the evidence-based practice. And nowadays, we try to do an active approach as possible in rehabilitations, avoid just using a passive therapy, and finally reinforce the self-management. So I think that will be the end from me.
Yeah, thank you very much, Candice, for such a comprehensive overview of physiotherapy. And so we probably will have around 10 minutes for discussion. So for the hub members, feel free to provide your opinion or views in the chat box. So my first question is for Professor Anwar. So you mentioned that the major process of rehabilitation is really to bring a person to the to attain the highest level of independence. So I guess after the initial assessment, the very first step is probably to set a goal together with the client. So can you share with us your experience? When is actually the good time to set this goal? Is it at the very beginning, or is it a really dynamic thing where whether this can be changed during the process? And if your goal and the client's goal might not match, then
Yeah.
what would you do in those scenarios?
Thank you so much, Grace. That's actually a very good question and very practical scenario, you know. So often what patient wants can be very ambitious. And I think it's not wrong for them, right? Everybody wants a good quality of life, but your quality of life or definition of quality of life might be different. And at the end of the day, we are talking about two things. There's one is performance, one is potential. Okay, so you know, you can have potential, but if it's not developed, then your performance is not anywhere near that. So anyway, let's come back to the answer to your question. So yes, the barrier, I think in general, in the barrier to rehab is cognition. So if a patient has cognitive issues, then we usually go to carer training or other measures. So that's why I was concerned when Yifan presented this case, you know, when our Jane here has got a little bit of a concerning complaint when she starts talking, you know. So you really want to know what's going on. Is it a medical condition? You know, was it something that she's taking? So if you look roughly at the drugs, she did not have anything very sinister. Okay. She's not on strong opioids or any drugs like that. So are we looking at geriatric depression? Are we looking at psychological condition, anxiety, depression, what have you? So, and it's very important to address all of that because we are not talking about rehab as what Kenneth said. It's not all passive stuff. There are things that you need patience engagement. And a cognitive challenge patient can make it very challenging. So we understand sometimes in our geriatric population can be, it can be adapted. It's not impossible, it must be adapted. So goal setting has to be done early. Now, patients can have, you know, I want to fly to the moon and everything, but our duty as a rehab team member, so both physio, rehab physician, occupation therapists, there's so many of us actually, exercise physiologists and so on, is to see in the ICF framework, what is the urgent priority? Now, if you ask me flying to the moon and actually to be able to wipe your bottom, to be able to clean up after yourself, which is of more urgent priority, right? Is to be able to take care of yourself by doing your personal activities of daily living. Because if you're unable to do any one of personal activities of daily living, you need nursing care. Now, I'll say that again. If you are not, so you're able to clean up after yourself, you're able to put on your dress, you're able to walk to the dining table, but you can't feed yourself. Despite full cognition, you need nursing care. You need some, so you're not independent. And when you need nursing care, you're talking about different set of environmental setup. Maybe you can't even live in where you are right now. You need, you know, in extra help. You need probably an NG tube, etc., etc. So it's a different ball game. It's a different functional goal altogether. So setting goals needs to be done early. So that's the answer to the question. Needs to be reviewed. And that's why rehab is done in a cycle. It's not like a journey you start from bedbound and suddenly you go to the other end. It's a cycle. So for this cycle, what is it I need? I just need you to get from your bed into your wheelchair independently, full stop. So we are going to break it down. It's just like how in medical school we learn about developmental milestones, right? So a child, a baby doesn't just come out from the womb and then starts running. You have a developmental milestone. So the same thing goes for function. There is this thing, it's not really encrypted, but we know it as functional milestone. So if you are able to lie to sit, or even before that, bed mobility independently, lie to sit, sit to stand, stand to walking, and then so on and so forth. So that we break it down. And then every cycle is to achieve that. So the biggest hindrance will be pain. So that's why I put relief as my number one issue. And I think Yifan also noticed that when the patient is within her environment, pain is not such a big issue. She's independent when she's out. Now, the second question, reviewing. And that's why if you look into the cycle, every EIO, the outcome always ends up, the end process always ends up in assessing whether the patient achieves or attains a functional goal or they didn't, or what happened. So then we can tweak maybe the intensity of the exercise. No, maybe the pain was not well controlled. Maybe the patient did not understand the instructions, whatever it is. So function, as much as it sounds very vague and fluffy, and is actually tangible if we have a framework, and that's why we introduced the ICF, so that we can understand the impact of a particular disease to a particular patient with, in terms of how they can do their activities and their participation, and then how then we go about achieving control over the impairments, control over the pain. How can we improve the range of motion? Next, we move on to the participation. Next, we move on. Activity limitation. Next, we move on to motion. So it's always a continuous cycle. When do we stop? Okay, so if you have achieved your functional goal, or when and good. Sometimes we have to make a call. We may not be able to rehabilitate, but we can compensate. So you might not be able to walk hands-free, but you can walk with a walking aid. So we need to make. So this is when, again, Grace, I go back to my first statement, potential versus performance. So we have exhausted your potential and your performance is just that much, then we will compensate. If we have not exhausted your potential, we can still push your performance, then we will continue to push as much as we can. So the trade is to find out where can we push you in terms of your potential.
Yeah.
Thank you.
Thanks very much, Anwar. So my second question is I think maybe for Barry. So for this patient, we have heard her story, so we can imagine that she has experienced a lot of trauma since a very early age. And as Professor Anwar has mentioned, pain is not really just a sensory thing, but the emotions, mental health can also impact on how we perceive pain. So Jane is now at the age of 70. So do you think it's actually something we should do to sort of go through all her past trauma and sort out sort of her mental or emotional component of the pain, or rather just focus on the physiotherapy and the physical problem? So do you have any views on that?
Yeah, I guess there could be two aspects of work in terms of psychological work that we can do. I think one side would be managing her trauma or symptoms of schizophrenia, but then there could also be more rehab-oriented kind of psychological work that we can do. So it really depends on the goal of what we want to achieve. But I mean, in terms of in this context, in terms of managing her pain, I think I would agree with Anwar and Kenneth about being active as an active ingredient for the patient. So my experience, because I mean, part of my old job was working in the HIV clinic, but part of it was also in the neurorehabilitation ward. So sometimes I would see my patients coming from the ID ward to the rehabilitation ward before they go back to the community. So sometimes I would see like patients because I remember one of my patient, he got like anxiety about using the stairs, having been lying in bed for a few months. So he has lost his confidence of using stairs, but he had to use stairs to go back home. So it was like I had to check back with my physiotherapist colleague in terms of his physical functioning. He actually has a good power to use the stairs, but he lacks a little bit of steadiness. So it was, I mean, like he still had to have a bit more physiotherapy input in terms of that. But it's more about his anxiety, about his own ability. So it was the time that we had to test it out. So we set up a behavioral experiment, which is more CBT kind of work, which is more cognitive behavioral therapy. So we identify his worry, which is falling off from the stairs. And then he didn't really believe that he would have the strength to walk upstairs. So we tested out with the stairs in the hospital, and then he predicted that he would fall down. But then it was like, I mean, a slim chance that he would fall down. I mean, from physiotherapist colleagues' assessment, and then we understand that it would be able to help him to collect new evidence to verify if his worry is warranted. So that we walk upstairs and walk back downstairs, and he managed to finish all that. And then we just let him do another round without much support of that. So it was in the first round, we sort of like holding his shirt to let him know that we guarding him. But then on the second round, we just standing next to him. So we're walking by next to him. So not really holding anything of him. So just in case if he falls down, then we can hold him. But we didn't really give him any support in the second round when he was walking up and down the stairs. And he managed to do that. And then it was also like an anxiety in the family as well. So we videotaped it and sent video back to the family, so the family will be able to see that he's actually managing well to do that. So it's sort of like, I think this is more rehab oriented, kind of like what we call it, or psychological rehabilitation, that we would give the input to facilitate patients to engage on the rehabilitation program. So I think this is more like the work that I would focus on, rather than focusing on treating the trauma, because I mean she has been living with the trauma for like at least 60 years. So I think she probably will have some way to manage it, and it's not very pressing at the moment. But I think like being active, it's helping her to focus on her quality of life at the moment. So I'm probably focused on the rehabilitation bit.
Yeah, thanks very much. I think you illustrated very well that rehab is really a very interdisciplinary matter. So, Norman, can I just very quickly ask Evan a final question? So from the community point of view, so we have heard about rehab. It really also involves a lot of active participation on the client's part. So from the community perspective, can you share with us how we actually can encourage our clients to participate more in or be more motivated in the rehab process, both the physical rehab and also maybe social participation?
I think that is a very big question. In our daily working experience, we found that the support system is very important. Today, Jen is staying in our shelter, so she's somewhat like isolated from the community. So I think it is more difficult for us to connect or to go on the same track with her, to build up the same goal, to do some like exercise therapy plans and so on. But still, we have some clients that they are maybe they are very young, and they have their ambitions, like they want to make money, they want to make boyfriends, they want to stay with their families. So we found that this kind of clients have more strong motivations to go back to keep on the therapies. So I think Jen is a very special client that she stay a very long time in our shelter, and she's kind of long-term survivors. So they like Jen will have less motivation. So I think isolations or motivations can't affect how we can provide services for them. Yeah.
Okay, thanks very much, Ethan. So, Norman, so would you like to wrap up the session?
Yeah, thank you so much, everybody, for your input and for the discussion. As we draw to a close today, just a very quick round of announcements. As you can already see in the chat box, the feedback form link is there. We would really appreciate it if you could let us know what you think about today's session, and for us to provide you with the certificate of attendance. We would have to ask you to complete this form, and we'll issue that. But this form is completely anonymous. We will not know who said what, but the system will issue that certificate for you. Next is that we are also still looking for a case for our next subsequent sessions. And as you can see, Yifan has presented twice already with us. And based on what we've heard from Yifan, he has learned a lot from presenting the case, two cases in fact. And so I would just also like to welcome everybody to submit a case, or if you think that there is something that's been bogging you, or something that you find challenging in managing a case in your local setting. We welcome that. This is an opportunity to learn, and to really perhaps learn from different contexts, how people from different places manage the case as well. Next up, we have an interesting topic on men's health. The didactic is going to be led by Dr. Tristan Barber, who is a consultant physician based in London and also an associate professor at UCL, University College London. And this is also going to be at 6 p.m. to 7:30 p.m. on May 14th on a Wednesday. With that said, I think that would be all that I have when it comes to announcements. CPD as usual, just complete the link that is in the chat box.
And can I just take over from you just to say and to let everyone know who has been coming regularly or is new here, this is Norman's last session with us as our coordinator. So I just want to say thank you very much, Norman, for coordinating and helping out. You've been very integral in setting this project up. So thank you so much. And I
Thank you
hope
so
that you'll be
much.
able to participate in the following
That was
session.
very unexpected. Yeah, I'll still be dialing in as a participant. So I won't be running away anytime soon. So I'll still be bugging everybody. But yeah, thank you so much. It has been a pleasure.
Thanks, Norman. All right, then. I guess we're going to draw the session to a close. So thank you to everybody, and see you next month.
See you.